I guess I can start. Jose is going to introduce me a little bit, but I talked a little bit earlier, but my name's Adam Wolf. I'm an internist at Metro, and I've been on the board for about 3 years now for JDRF. So it's something, complications are something that I never like to talk about with patients, and I'll talk about why that is. But from a financial standpoint, I don't have any disclosures. Dr. Jimenez Vega has a couple, so I'll give you just a second to look at those. I will tell you that knowing him, these are all about bringing the best treatments to patients in the most efficient way possible. So this is kind of what we structured the talk to be a little bit today. And again, we'll have some time for questions after, but understanding kind of what T1D does to the body, historical implications, where has the data and the research come and around the treatment of type 1 diabetes and complications, and then thinking about limitations of A1C. And what are some of the new targets that we're looking at in and around treatment? What can we do today to prevent bad things from happening? Get caught up here. To prevent bad things from happening. So what are some things that we can do today or at our next visit with our endocrinologist or our internist or our family medicine doctor to think about where we need to go and what can we do to prevent that bad stuff from happening? Understanding a little bit more about the progress that we've made in treatment and then how that's correlated into complication reduction. And then what are some of the things that we're looking at in the future? So that's kind of the gist of what we'll talk about today. I think what we're in this interesting time, I think, in the treatment of T1D now. A lot of kind of historic thought was, complications, we're being very reactive with treating these complications and really by and large we're moving towards a very proactive approach based on some data that we have from a long time ago and then some more recent data which we'll touch on as well. So I think, and I think we all, at least those of us on the stage, think about this as changing the dialogue. That's one of the things that JDRF has allowed us to do is really change that dialogue around treatment of type 1 diabetes, but also prevention of complications of type 1 diabetes. So understanding the complications and what leads to complications, I think, is critical, and that's why you're here and why you're listening today. So if we think about mortality, looking way back into the pre-insulin era, within 20 months of diagnosis, around half of the people who were diagnosed with T1D didn't make it. So progress, right? 1922, insulin was discovered. Patients lived longer. That 20 months turned into a 20-year reduction in life expectancy. 1922, progress again. 20th century, here we are. Survival gap is essentially nothing, 1 to 2 years maybe. And that's just unbelievable progress that's been spurred on mostly by what we've done technologically and the treatments that we have to prevent those complications. And I put that picture up on there as well. This is the biking team from Team Novo Nordisk, and companies like Novo and Medtronic and all of these companies are critical to not only living the life, and these are all people with type 1 diabetes and who ride competitively. And I've participated in a ride. This will be my third year riding, or fourth year, I should say, riding for JDRF and raising some money for that, which is an awesome thing as well. But always amazed at people that come out who have type 1 diabetes and ride 100 miles with me. It's absolutely amazing, and it just blows my mind. This is kind of this concept, I think, historically that we've always thought about. We think about complications of diabetes in a very negative light, which they are. But I think that fear often can be motivating, but I don't think it's the best motivator. I think that fear is something that we should kind of move away from when we think about complications, and I think we need to, again, think about that proactive approach and thinking about how far we've come with treatments and prevention of diabetes. Understanding a little more about complications, we kind of link these into two buckets. The first bucket are microvascular changes, and this is the stuff that you probably talk about with your physician on a regular basis. Did I get my eye exam? How's my kidney function? Did I get my microalbumin done? How are my feet feeling? Do I have pain? Do I have numbness? Those kind of things. So these are all microvascular, small vessel changes, very important, and we have very good data to show that and I'll go through this in a little bit, that better management, earlier and more aggressive management of type 1 diabetes in particular, reduces your risk of microvascular complications. Then there's the macrovascular stuff, right? Heart attack, strokes, peripheral arterial disease. These are the things that we actually don't have a lot of great data. Anecdotally, we have a lot of good data. Absolutely, there's a reduction in these events, but we don't have good trials out there yet to show that specific therapies reduce your risk of macrovascular events. But that's kind of where we look at things within the medical field as far as microvascular, macrovascular events. It's always important to think about management of blood sugar in this light. And we talked about that progress, right? So this is a graph that just depicts where we've come from 1990 to 2010. Oops, sorry about that. Oh, geez, I'm trying to do two things at once. Sorry about that. So let me just go back to this one for just a second. And then thinking about those two buckets and microvascular and macrovascular events. So again, microvascular being the eye, the kidney, the neuropathy that we talk about, and then macrovascular events being stroke, heart attack, and then peripheral arterial disease or blockage of the arteries and the extremities. And all of this is very important with improved blood sugar control and improved blood pressure control. But we have much better data historically and more recently to support the reduction of A1C and improving blood sugars with microvascular events. So this is a graph that just depicts, as I mentioned, what we've done, and this is a graph looking from 1990 to 2010, so a little bit old data, but still pretty good data, and the numbers are just awesome. I mean, if you think about each of these different things that can happen, we've made amazing progress within 1990 to 2010, and I would argue even more now, although the data is not out yet. 68% decreased risk of heart attack, 52%, almost 53% decrease in stroke, 51% decrease in amputation rate, and kidney failure is down almost 30% as well. So this is just a testament to what you do every day to control your blood sugars and what progress we've made with technology, a lot of the research going on through JDRF and other organizations as well. This is really how we want to think about type 1 diabetes. Each of these athletes is a type 1 diabetic. Each of these athletes is functioning at the highest level. And this is really where we've come with T1D treatment, is to think about anything being possible and living with type 1 diabetes. So this is where we need to go. So I talked about a couple of the trials, and I'm just going to briefly talk about these. I don't want to go into too much of the nitty-gritty as far as the statistical analysis or anything, but suffice to say that these are kind of what we say landmark trials, meaning that these are trials that truly have changed the way we think about treatment of type 1 diabetes. Going way back to 2003, and the DCCT trial, the Diabetes Control and Complications trial, conducted again from 1983 to 1993, which is, thinking about that 3 decades ago. And they showed unequivocally that there's a significant improvement in complications, early and late complications, if you have better control of your A1C. And that was the target that they looked at, was A1C. And I've got a graph on the next slide that'll kind of show that a little differently. A follow-up trial to that, the EDIC trial, and that looks at kind of that same population of patients in the DCCT trial, but looks at it long-term and how are these patients doing 30 years later. And it seems to be that the findings are the same. There's a consistent and lasting effect when you control blood sugars earlier and more aggressively.
So we need to rethink about these things. And then the patients have different glycation rates. So there is a term now coming up that is called glycation gap, that when we compare different things, we can say, well, this patient has a glycation gap because the A1C doesn't compare to what we're seeing on the numbers on the CGM. So just another fun slide, another study. And this is very interesting because this is the only study that I have seen that you can cure diabetes by treating their anemia. If you see at the third column, you see that their A1C was 7.7, but after they were treated with iron, their A1C went down to 6.4. So again, I'm not saying treat your child with iron and that will fix your, that will cure diabetes. But again, I just wanted to point it out how variable the A1C can be on a patient. We talked about the racial differences. So the numbers could be 0.4 percentage points higher in some up to 0.8, depending if it's thalassemia or sickle cell disease. So in the end, what I'm trying to point out and let you guys know today, that glucose is the enemy, not the hemoglobin A1C, okay? And this change in the dialogue requires changes in the way we express on things and what we talk in the targets, okay? And again, I love this picture because, I mean, when you guys get that A1C on target, that's how a lot of us feel, right? So now, when we talked about the glucose fluctuations, we have to put everything in a balance. We have to have good glucose control. We have to try to reduce the variability of the glucose. And then we also have to take into account the risk of hypoglycemia. We can't just be overbolusing all the time and leading to hypoglycemia and then treat it. That's not the goal either. And so we have to also take into account the speed by which we're trying to treat and the magnitude, the amount of doses that we're trying to do. So all of that is a really fine balance, and this is the way that now, as technology has been evolving, both from the commercial part, where we're seeing systems like the 670G that has the hybrid closed-loop systems, as well as the ones that are going right now on trials, like Tandem and Omnipod, and then the parent-derived options that are out available for some patients to do. All of that is trying to target that situation. So we talked about glycemic variability a couple of times, but we basically, it's kind of a little bit of the same, this slide, you know, the risk of the hypo and the hyperglycemia, the amplitude and the timing of the blood sugar. The increased variability is associated with mortality in the intensive care unit. So that's also why we are not trying to extrapolate that data, but basically we're trying to reduce that glucose variability. And it's a consistent predictor of hypoglycemia, meaning that if you're having a high glycemic variability, you're gonna have issues with hypoglycemia. So here's one slide that I wanted to point out so that no A1Cs are created equal. So these are two different patients, patient A and patient B, both with the same A1C, 8%. And what do you guys see? You see that patient A has a lot of highs and a lot of lows, but still the A1C is 8%. You would say, okay, they're doing fine. And then you see this in the clinic, you're like, okay, you're like a yo-yo here. Patient B looks really good. You know, spikes a little bit here and there. That's what we expect. It's not gonna be perfect. Never is gonna be perfect. But stays in a certain range and goes low, but doesn't go that low. So that's where we want all to be. And that is what we feel that is going to bring significant benefits as we move on forward with the technology that is being created, and JDRF is being part and involved in trying to develop all those things. And just to stir the pot a little bit more, Adam Brown, so he's our keynote speaker. He's going to be doing the closing speaking session today. He is the senior editor for Diatribe, and recently he was in Vienna at the ATTT meeting. This is the Diabetes and Technology Conference. It's celebrated every year in Europe. And so he presented this 42 different factors that can affect blood sugar. So there's the link where you guys can go there and look into that. And again, all this, you guys will see it. Stress, illness, episode of hypoglycemia, not having issues with the Dunn phenomenon, issues with how it's delivered. Spring is coming up. Allergies, anyone is excited about that? And the blood sugars. Periods, you know, that's also so much fun, you know, because then you have the pre-period and then the after period, because they're having lows initially and then now they're having highs, or vice versa. You know, each patient is different. Puberty, those hormones, so exciting, exercise, now they're all the different sports, they were being more of a couch potato because it was so cold, and now they're doing all this sports, and once you had figured it out, now they're dropping again, and you're like, oh my gosh, what do I do now? So there's so many different things, the carbs, the type of carbs you're giving into, there's so much, and so we're all trying to just be exposed, be aware of those things, and trying to get it into a better control. The other thing is, so we've talked about how we're going to be able to measure this. So this is going to be made through continuous glucose monitor. And so just want to point out that there are two different types of CGMs currently in the market. So there is the Freestyle Libre, which it's currently FDA approved for patients over the age of 18. We have used it as an off-label use, and I am aware that they have submitted to the FDA for approval in the pediatric population. And then Dexcom is the other one that has been approved and has been for many generations now. Current generation is a G5 system. They're coming out with a G6 system by the end of this fall, which will have different benefits. But basically, what I want to point out is the difference between one and the other. One is called the real-time CGM. So that means that you're getting the measurements, and they will be streamed through Bluetooth to your app on your Android or iOS device. And that could be streamed live through the Share app. Or you can send it to your phone. You can send it to either, if it's Android Wear or Apple Watch, whatever you guys want to do. The Freestyle Libre, it's an intermittently view CGM. So what does this mean? Actually, that one is not transmitting the data at the same way as Dexcom. It has its own device. They call it a wand, and you have to swipe by the wand, and then you will get the reading. So you have to be swiping in order to get the data. The data accumulates, the longest data is about 8 hours that you can accumulate in there. After 8 hours, if you haven't swiped, it will rewrite and overwrite the data that has been screened in there. So when we download the reports, we could see some gaps in the data. So when I have these patients, I tell them, actually I don't tell them every 8 hours, I tell them check every 6 hours so that you be sure. But again, sleep, they're staying up all night, and then they stay sleeping until like 2 in the afternoon. So those are the things that you guys have to be aware so that you can check it and you do that part so that we can get all that information, okay? And the benefits of the real-time CGM is that it has been shown that it improves the glycemic control and the quality of life in both children and adults with type 1 diabetes. So it improves not only the A1C, and also, but most importantly, reduces the time spent in hypo and hyperglycemia, and reduces moderate to severe hypoglycemia, leading to reduced overall diabetes-related complications. But the most important thing about this is not just putting the Dexcom on and say, hey, now I'm getting all these benefits. No, you got to use it. And so you got to follow what Yoda says, and so it's very important to use it and take advantage of it. Learn, look at the trends, see what the things are happening, what are causing things, because then you will learn even more. It will teach you, did they spike after getting stressed? Did they get into a big fight with brother or sister, and now you see their blood sugars up in the 400s? What things are going to be happening that will be helping you to use things? And so when I say using things is either, do they need a shot right now? Or do they need a correction? Do they need to have a correction? Do they need to do a change in their basal? Is there something going on with the pump? All those different things that gives you more tools along the way. I wanted to show here the different reports that you would get depending on the system. So I mentioned only Freestyle, Libre, and Dexcom. Medtronic has their own sensor that works with the 670G, but this has been only FDA approved as their own, as a system, not as a separate entity by itself. This was more because of production issues to be able to meet the demand that they were having with the 670. I would expect that by the end of the year or next year, they will have their own separate system. But as you can see, on each of them, if you look at, for example, the one in the middle, it will talk about the average blood glucose and then the standard deviation. So that would be part of the glucose variability, and then the hypoglycemia risk. If you look on the right side where you see the Medtronic report, you will see also that it has different colors. You have a dotted line that basically that's the average blood sugar of that patient. And then you see the light pink and light blue signs. And those colors show about 25 to 75% of when the patient was on around those ranges. And then the light dotted ones shows a little bit more of extremes.
And then the other thing that we keep in mind, but also you should if you're in the ER or med center, if there are any radiologic testing being done, that's really important to let people know and make sure that they understand that you do have type 1 diabetes and that, or that your loved one has type 1 diabetes, so that they can take that into consideration. The big thing around that is really hydration, staying well hydrated prior to any radiologic procedures. Blood pressure, again, critical. As blood sugar is critical, blood pressure is as well. Current goal and guideline really came out late last year. Really puts the new blood pressure goal at 130 over 80 or less all the time. And so if you're not there, if you're checking blood pressures at home, if you're seeing those numbers that are higher, ask the question, should I be treated for this in the office? It's an important risk factor, as I mentioned, both the macrovascular and microvascular complications to reduce the risk of both of those things happening. And there are obviously great, well-tolerated medications to help with diabetes and blood pressure as well. Low-salt diet, as far as blood pressure goes, is one of those things that we talk a lot about in the office. But just to give you some numbers, what we shoot for is usually around 2,000 milligrams or less of sodium, which I think sounds like a lot when I think about it. But when you start to read labels and add up those milligrams, it's not a lot of salt. So often it's not what we add to what we eat, but what comes in the things that we buy at the grocery store that are most high in salt. So something to definitely keep in mind as well. When's the last time I had my feet checked? I check every one of my diabetic patients at every visit, and that's kind of what we do as a routine in the office. Insurance usually recommends that we do it once a year, but that, in my opinion, probably isn't enough. Again, a lot of things that you may not notice at home. We can see when we do a good inspection, and that's a really important thing to prevent any sort of complications from skin sores or anything like that. So anything, even a little blister after a long run or something like that, to let us know right away to make sure that that's taken care of appropriately. And then cholesterol, again, one of those risk factors along with blood sugar and blood pressure, looking at that overall risk profile for our patients with diabetes. ADA recommends what we call statin-based therapy, which are the typical meds that we use, Lipitor, Pravachol, Zocor, those kind of things. Those are really the only medications over time that have been proven to reduce cardiovascular events in patients with diabetes, or with any patient for that matter. And these are the recommendations, really. If you're less than 40, if type 1 diabetes is your only risk, probably don't need statin therapy unless we have compelling reasons otherwise. But then 40 to 75 plus, we look at your risk factors, and the guidelines would say that probably almost everybody, if not everybody, benefits from statin-based therapy after that age group. So we put together a few take-home points, and we'll kind of tackle these together, and then have some time for questions after. But I think we touched on this with both Jose and my talk, that really A1C is very important still, but it's not the whole picture. And I think to treat the glucose is really a better way to kind of think about that as well.